My name is Beverly Norman Cooper. I'm the Executive Director of National Supplier Diversity at Kaiser Permanente. And Motz and I are actually colleagues under an organizational structure that we call Buy to Pay, not Buy to Pays, Buy to Pay. And it looks at everything from how we buy, source, including from diverse suppliers, to how we pay. And so that's an organization that was, it's been around only about a year and a half at Kaiser. Before it was different discrete functions, but we're now under one umbrella, so to make it a seamless experience.
Okay, great. Good afternoon. My name is Ravi Anupindi. I'm a faculty at University of Michigan in the Ross School of Business. My research and teaching interests for 2+ decades has been in supply chain, though in the last few years I've begun to use the supply chain lens to look at 3 areas. Role of supply chain in economic development, which kind of relates to in the healthcare space that we've been talking about earlier. So role of supply chain in economic development, role of supply chain in sustainability, and in healthcare delivery. Though I would admit that my focus in looking at healthcare is in low and middle income countries and not United States. And as we were discussing earlier, there are actually great examples, because issues that we might end up talking about in this panel are even starker in some of the low and middle income countries. And so what can we do there versus what can we learn from what is being done in the United States is something that I look forward to discussing.
Yeah. So I'm Liz Schwalbach. I'm the head of human resources for Goodwill Southern California. So that is 3 counties, Riverside, San Bernardino, and Los Angeles. And what we do, I think a lot of people are probably familiar with our stores. There's 80 stores in our footprint, and that sells used goods. But we use the money from donations that we have to go ahead and fund our mission, which is transforming lives through the power of work. So it's really helping people who are underserved and who have barriers to employment, having opportunities to better themselves and work experiences so that they can go ahead and have a better life going forward. We help about 55,000 people a year. We have career centers that people can go to find opportunities and also get training. And then we also employ people ourselves, and we find job placement for them in the communities. And additionally, we have side businesses to try and help people who are underserved as well. So that's what we do.
Hi, I'm Nita Stith. I am the Vice President for Finance and Supply Chain Strategies for Providence St. Joe's Health System. We are 50 hospitals representing about 900 clinics and untold number of physician practices across 7 states. We cover about 2 million covered lives. We are a recently merged organization with corporate offices both in Renton and Irvine, California. We are a faith-based organization that has been in the community for many years. Our focus is very much community-based and mission-based for those that we serve. So, happy to be here with you.
I'm happy to meet you. My name is Mike Vestino. I'm the Vice President of Support Services for Pomona Valley Hospital Medical Center. I'm an adjunct professor at the University of La Verne in their Masters of Health Administration program. I teach here a little bit on the Lean Six Sigma Yellow Belt course, so that keeps me busy. And I'm a board member here for the Global Supply Chain. Our hospital is a standalone, not-for-profit, 423 beds. We deliver roughly 8,000 babies a year, which is within the top 2 or 3 in the entire state of California. So it keeps us busy. But being a standalone hospital, we have to group together, or band together with other like hospitals to try to negotiate our supply spend. So that's a big focus for us. We partner with Cedars-Sinai and other big not-for-profit hospitals.
So to kind of kick off the discussion, I wanted to actually talk about Liz's organization, which is not healthcare, right? Everyone else here is involved with hospitals and delivering care. But when you think about Goodwill Industries, that organization is about, it works a lot like supply chain, right? You've got products coming into retail, and it's got to go to distribution center, and you got people working, you got a lot of moving parts. And so there's a big supply chain element to it, right? But the mission of the organization is to help people, right? The mission of everyone here at the table is also to help people. And what we all have in common here is the thought of what are we doing to help better people's lives, right? And you can help people's lives if you go to the hospital, right? But usually if you go to the hospital, you're already in trouble, right? People don't come to the hospital for vacation. What we're going to talk about is what are we doing to prevent you from having to go to the hospital? And what does that mean? And so there are different terms for it. At Kaiser, we call it total health. But it really revolves around what Ravi talked about as kind of this, what we call the social determinants of health. So as anchor institutions, whether it's our mission like in Liz's area, or if it's a component of our overall mission in the healthcare industry, the question is, what are we doing beyond providing care when you come to us and you're sick? What are we doing to project out and prevent you from having to come in? And that is something every organization can do, right? Doesn't matter if you're in food or food production or academia or any other industry you could think of. The question is, we're spending a lot of money in supply chain, what else can we do, right? And not think just about the bottom line, but think about the long-term implications, because if you are a manufacturer and you invest in the health of your community, guess what? You're probably going to have better employees, right? And so what we're going to start with is the easy question. I'm just going to start with question, which is, if you put your cap on in terms of how am I helping beyond my four walls, right? How am I helping the community I serve? How am I helping the supply base that is part of my supply chain, regardless of what part of the world it's in? What is supply chain's role in improving the health of that supply base, improving the economy of that supply base, beyond just injecting more money because you're buying more stuff? So who would like to start with that question?
I'll be happy to start. You know, one of the things that I will say, I've been in the industry now for 39 years and have watched the shift in supply chain from a healthcare perspective. And as we've entered into this new era, it has become very evident that supply chain is more than what has been in healthcare, a very traditional box moving, very tactical structure. And with that said, at Providence St. Joe's, what we have done is we've turned our supply chain into what we call population health supply chain. And the meaning behind that, the genesis of that, is to say we are actively engaged with our spend collectively. We are affecting many, many areas of our social responsibility, our footprint across the globe, because we're buying tons of things. And our approach is to say supply chain will be connected to the outcomes of the patients based on the products and goods that we use. So what we have now done is we have connected all things that we acquire as we work with our suppliers, whether it's a medical device or it's just a commodity-based device. We've taken that information where we are purchasing supplies and connected that to the patient records so that we're able to see outcomes associated with the use of those products. Connecting variability between a little bit of correlation between the products that are used and the records that show to us how that product has factored into the outcomes, the length of stay. One of the reasons that's very important to us is in the past, in the healthcare world, you had two separate silos. You had the clinical silo, and then you had the business silo. And the patient at the end of this process. They were presented with a bill, but they could not correlate the two activities. And so the contracting or the sourcing structure would go out and they'd contract things. I used to say we were the economic buyer and the physician was the buyer, and there was no connectivity between the two. We have actually changed that to say, if we are going to be a part of our patient's health, we in supply chain absolutely can impact that through the goods and services that we offer. That clinical evidence associated with those goods can no longer be just that relationship between the physician and that patient. We recognize that patients have become far more savvy. I've listened over the past 2 days to the manufacturing world. They've locked down that their customer is very important at the very beginning. It's about their demand. It's about their need. In healthcare, that's just reaching a level of low maturity. There's not been an understanding that the patient is a big part of their care. So in supply chain, we've linked those two worlds. We are now beginning to work with our suppliers based on the outcomes associated with their supplies. That's very different because it also talks about how you go to market and you contract. So for us, we have taken a very different approach to how are we really affecting that population. And one of the other things that we've incorporated in our strategic direction is around the social responsibility that goes along with that footprint. A very large program is being developed now that talks about how are those outcomes, how is that volume, how is all of that activity, what is our social responsibility to that? And that also leads to how we partner in the end with our suppliers.
And if I could piggyback off that, and I think one of the things we're looking at Kaiser is very similar, right? Because when we started a couple years ago, I think we got very deliberative about this whole concept called total health, right? And what we said is the clinical outcomes, I think research says that clinical outcomes are only 10% of any determinant of how healthy and how long you're going to live. It was all of these other socioeconomic things. And there's an expression we use that says zip code is a better determinant of your longevity and health outcomes than your genetic code. So clearly, if you look around and you live in an area that is high poverty, high crime, food deserts, lack of access to healthy walking parks, any of that, it doesn't matter that you come to Kaiser and you get great clinical care, as Motz said. If you get great clinical care and you go back to that environment where your housing is unhealthy, the air you breathe is really unhealthy, you don't have access to healthy grocery stores, you're gonna still end up back in that situation. So what we're saying is we really are going to start to put a lot more emphasis on the upstream determinants of health. So where supplier diversity comes in is we have about a $16 billion spend in our procurement and supply space. That's sort of there's a little bit, it's a lot more than that, but the $16 billion that Motz is in our organization controls. Supplier diversity spent last year $1.68 billion of that with diverse suppliers, women, women and minority-owned businesses. And one of the reasons why that is so important to us, we ended up being the first healthcare organization in the $1 billion roundtable, of which Toyota is a member as well. And those are companies that commit to spending at least $1 billion a year with minority suppliers. And again, for us, that was really important because if we look at the members in the communities we serve, a lot of them are from diverse populations. If I can do business with a small, diverse company in Watts or some other part of LA or West Oakland, then that means probably that company is going to hire from that community. You start to create economic wealth in that community. The whole economic development cycle begins, and ultimately you're going to get to people who are going to put grocery stores there or food markets. So we're really looking at the entire ecosystem. And then Motz said, talk about this other project. So part of what we also know is For our diverse suppliers, a lot of them are smaller and they don't have the capacity. They could never do business with, we would bankrupt these people, right? So what we said is, not only are we going to say that we're looking at our diverse supply base to help create better health outcomes, we recognize that we have an obligation to also develop them, to help them with their strategy, to help them with the financial operations, to help them with supply chain financing, help them with marketing, help them with learning how to pitch. So we have a couple programs at Kaiser we started this year. One, we're partnering with Harvard. Michael Porter has this whole concept around clusters, anchor institutions. So we're partnering with them to do some capacity building right here in Watts with about 103 businesses over the course of the next several months to really, again, help them to develop the capacity to do business with some of you folks out there, because we know that we can't create that health outcome on our own. So those are some of the things, again, we're doing, because to Motz's point, if you end up in one of our facilities, but you're not addressing all the other issues that got you there in the first place, in 10 years, you're going to come back. And that doesn't really help to create the health outcomes we're looking for. So again, we're looking at our supply chain, our procurement spend to really drive economic development in all kinds of innovative and bold ways, because again, we recognize that if you end up in a Kaiser or any of these other hospitals, at that point, it's just because you're sick. You're sick, and we have no way to help you get healthy. And that's really kind of what our focus is.
At some of our job centers, we also have a challenge where a person comes in, they want help finding a job, but they have some underlying issues with their total health. Maybe it's PTSD, if they're a veteran, other things that make it very hard for them to go ahead and accept the coaching or counseling or be organized enough to be someone that we can refer into a program. So often we have to really assess them and talk to them about what their situation is, and then partner with other agencies to make sure that they have some of the fundamentals okay, so that they can actually succeed in a program. Some agencies are pretty good. The Department of Rehabilitation really helps try to assess whether or not the people that refer to us are ready to go ahead and have an experience where they can show for 6 months that they can have a steady job, that kind of thing. But other people who come in really need support from other agencies. And it's a challenge, because if the person's having so many other things that they're burdened with, it's hard for them to hold a job. So that whole network of total mental health and then being well enough to do it is very important for their long-term success.
Other thoughts?
Yeah, I mean, I can bring in a little bit of the low and middle income country perspective, but I just want to kind of, before I get to that, just, I was recently teaching a class on healthcare in China, and as I was preparing for that, I already taught that, it's this notion of healthcare, people, all that goes into, when people talk about healthcare, they're really talking about sick care.
Mm-hmm. Yeah.
And I think what you're referring to really is health is both sickness and wellness. And there's very little attention paid to the wellness in terms of the upstream part of it that you were talking about. I think it's very heartening to see, bringing the focus back on that. Now, coming back to the role of supply chain, so let's think about low and middle income countries. And we do some work in the global health space, which is mostly today in communicable diseases. But if you look at, and the biggest funder in that space is the Gates Foundation. The Gates Foundation, our primary focus has been health for a long time. In the early days of Gates Foundation, they put a lot of money in what I would call innovation or discovery. And discovery of neglected diseases, vaccines, and all that stuff. So as that pipeline started getting full, suddenly they realized that, well, discovery is necessary, it's not sufficient. Because just because you have something doesn't mean it will get delivered to the point where it needs to be delivered. So there's a whole program that just started called Delivery. And they show some fantastic graphs in terms of, if you think, it's hard for me to kind of, I don't have the graph with me, but I can highlight, if you think about new product diffusion, and broadly, but if you look at healthcare product distribution, let's say in the United States, over time, if it is ramping up like this, in most low and middle income countries, it's almost flat and goes much more slowly. So why is that gap? Why does diffusion not happen in low and middle income countries as fast as it happens in developed countries? And that gap simply is a delivery gap, delivery very broadly defined, and supply chain plays a very, very, very critical role in delivery. And what are the things that are happening? If there is no product there on the shelf, you cannot treat anybody, right? So, and within that, you can start seeing disparities, urban areas, rural areas, same issues that you probably will end up seeing here, perhaps less stark, but it's still there. I mean, to your point that it is zip code, not genetic code, yeah, I mean, it is a big issue. So I think supply chain has a very, very critical role to play, even the classical way of thinking supply chain, and in a resource-constrained setting. And that, to me, is a much bigger challenge to think about how do you even run your supply chains in a resource-constrained setting. And most often, the supply chains in at least Africa are not even run by private parties. It's the Ministry of Health control. And there are humongous challenges in terms of, and so there's a lot of focus, a lot of effort, a lot of money going into how to improve the healthcare supply chains of all these, low and middle income countries primarily is a big, big issue. So, I mean, that's one place I see. There are many other ways, but that's one place I see supply chain directly impacting healthcare. Yeah.
So, Mike, maybe you could share with the folks here, what is supply chain even in the urban environment? Because I know operationally, we measure on-time delivery sometimes to the minute, which in other industries may not be as critical, but maybe you could share some of that because it's a different perspective.
I'd like to touch on this just a little bit on the local level. So in Pomona, so we have surrounding areas, and we have Chino Hills, we have Claremont. These are very high median income areas. But what I notice, I'm on the Lions Club. I participate in the YMCA, the Chamber of Commerce. There's Western University. There's Pomona Valley Hospital. But when I go to the meetings, what you find out is everyone's talking about population health, but nobody's really coordinating it. Everybody wants to do diabetes wellness. Everybody. So it's the hospital is in business to take care of people, right? We're a standalone not-for-profit, so we don't, Kaiser. I'm listening to what you're saying. It's wonderful. But we've been in business for 115 years, and what we do is we try to get people healthy. So to change that model, to me, it has to start at the city and the local level to help us coordinate those efforts, and I haven't seen that yet. There's a lot of talk, but we need action from that perspective. Then shifting to another direction, looking at local vendors and merchants. When I started at Pomona and I took over food and nutrition, my first year I reduced our supply spend by $1 million, right off the bottom line. That's not easy to do, right? How much revenue do you have to generate to take $1 million off the bottom line? But what happened to do that is you have to cut some of those local ties. I had an executive chef, Wolfgang Puck trained, and he's out buying local meats from companies, and I had to explain to him, you really need to know from where that product came from the very beginning. You just can't be out there doing all this stuff, buying shrimp from the local fish market and doing that kind of thing. So it's hard to maintain, as a big organization, the relationships with the small companies because they don't meet the regulatory requirements that we are facing today, and they're getting harder and harder and more stringent on what we can do. So that's what do you...
So let me kind of add to that
Sure.
an example that kind of ties to, I think, what you mentioned also with Beverly and some of the things we've experienced with respect to local suppliers and supplier development. And recently we have a landscaping, right? Every hospital has shrubs and grass and all kinds of pretty things outside. And we worked with a number of different landscaping vendors, right, all across California. And contracts came up, and you said, well, let's do a regional or national bid, right? You say, well, we should be able to get leverage and get one landscaping company that can cover, let's say, all of California. That would be great, right? We get lower pricing and better service. So that's not care delivery, but that's talking to, even food service, right? That's not necessarily directly tied to care delivery, but it's tied to your local supply. And so we went through that process, and one of our suppliers that handled a pretty large geography basically backed out. And they were a good supplier, good landscaping company. They backed out, why? Anybody guess? You can't guess.
They probably have got.
They backed out because they weren't ready to scale,
Yes.
Right.
right? So now what's happened? We can still be kind of bifurcated and have various suppliers, right? Because think of landscaping suppliers, they're generally smaller companies, right? Or we could work with that supplier to develop them so that next time around, they have the opportunity to scale. And they can grow with us. Does that do anything for Kaiser in terms of improving our bottom line for those 5 years of investment or whatever it takes to work with that supplier? Not immediately, right? But down the road it could. But what it does do immediately is it helps develop that economy for that particular supplier. Because they grow and learn and they can build their own business, which again creates better economics for that whole community.
Do you have some sort of time frame you give to your local suppliers, say they don't meet the requirements? So say 5 years is probably a long time. They don't meet.
Yeah,
I mean, it's a pay subsidy in a way, right?
Well,
A detailed subsidy.
so a lot of that is tied to kind of our contracting cycle. So if our contract, you know, for a certain type of service is a 3-year contract, so they know, okay, well, for 3 years, you know, we can work on things and improve, and hopefully in 3 years we reconsider this. So it kind of depends on it's generally contract driven.
And to maybe piggyback back up what Mott said, this particular supplier, because they had actually serviced us for 20 plus years, and when we talked to them about, you know, come on guys, you lost this contract because you've been grandfathered in almost for 20 years. You've been doing really good work for us, but did you not look at how supply chains are, you know, they're sort of rationalizing them, and you should, and they said, actually, no, we didn't think we needed a strategy. So part of, again, we feel an obligation to do some capacity development. So this particular supplier we brought to a 2-day event. We worked with them on creating a strategy. We showed them our 10-year strategy. And we said, you know, whether you do business with us or not, you need to understand where we're going in 10 years. And oh, by the way, we're also bringing in, as part of this 2-day workshop, folks like Jones Lang LaSalle, who have massive real estate, right? So part of what we feel, at least, you know, for us, is an obligation to, you didn't get this contract, you provided great service, and we know that local economies really matter. We need to help you try to stay in business, whether it's with us or somebody else, because ultimately the community is an ecosystem. And if you have, you know, 30 people on your payroll, we don't need those 30 people to not have jobs. So I think to Motz's point, it's like we can look at it and say, there's no sourcing opportunity right now because that contract is not up for 3 years. But what we're going to do is we can't say, EY, you guys do business with these people, but what we can say is we're going to facilitate an introduction. Or, oh, by the way, have you thought about a joint venture with so-and-so over there? We can't tell you to marry these people, but have you thought about that? So again, for us, it does go back to the upstream determinants of health. It is our responsibility and obligation to work with you to figure out how to get that community healthy at the local community level.
And, you know, I'd like to add on to that. One of the things that's actually happening, going back to having been a part of healthcare now for 39 years, I have to stop saying that. It just makes me feel so old. But in a broader perspective, healthcare supply chain has radically changed. And I think for the forward-leaning organizations, Kaiser, many others across the country, including Providence St. Joe's, you know, the supply chain function is really being challenged around how does it affect that community change. And contracting, I think, is one of the clearer, easier routes of getting to it. And how we contract when you're talking about organizations as large as, whether it's Providence St. Joe's or Kaiser, there are many across the country. We're talking Intermountain, we're talking Mercy. They're really having to look very closely at what is the model of supply chain for whether it's accountable care or just globally. You know, all of a sudden, the larger organizations were not just practicing in the United States, we're practicing outside of the United States. You look at whether it's Hopkins, who is now, I believe, in Saudi. We've got other organizations. They are not just delivering care in the United States of America. So that supply chain is becoming extremely broad and extremely global. So when you start talking about what does supply chain do to impact the health of those patients, you have to start looking at my leveraged contracts. What does that look like? How does my leveraged contract impact the vendors, the suppliers, the manufacturers? What is the plan for that? Whether it's national or global, how do we set our operations up to impact the care of that patient? So this is a brand new world for supply chain. Thinking in terms of more, a lot less of the tactical activities, but more of the strategic activities that have all of those downstream effects to our vendors, to our suppliers, but then in the end, ultimately impacting the care of that patient. And so that's one of the things that for supply chain leaders, executives, and organizations, that has to be top of brain. That strategy that says, what does my supply chain do to literally affect that patient? And there are many tactics, I would say, to that, connecting to all facets of the community, whether it's, I think someone said they were here from the city. You've got to work with the city. You've got to work with many community organizations and take that supply chain far more, I think, spread out to ensure that you're affecting the whole without harming the whole. And that's very, very important.
Any questions up to now? Someone got a question at the end.
A comment. Like what you said about you shared your 10-year plan with your vendor you're trying to help. And you mentioned these new directions. One thing that could be very helpful is to call all your key suppliers together and say, here's where we're going in the next 5 years. Here's the challenges we share together.
Mm-hmm.
And they have some responsibilities and some abilities and knowledge of their business that we as the buyer don't.
Yes, it's
And like really engage them as partners and then reward the ones that get the message and
Absolutely.
make it happen.
Yes.
And let me just add to that point. A part of our strategic plan is exactly what you said. So a lot of the cost in healthcare comes from whether it's our pharmaceuticals or our medical devices. In the past, the model has always been our physicians drove that with their relationship with the suppliers. So the manufacturers really had no connectivity to us. We were paying the bills.
Yes.
They had no responsibility for their marketing strategies that said that if you use this item, Dr. A, you're going to see more, you're going to see better improved outcomes, length of stay will be better. But there was never anything there between the healthcare provider and that manufacturer. So what we've done in our strategy is to turn that around and bring that manufacturer into what our strategic direction is and partner with them really around those outcomes. So if in fact it turns out from our data, because we built a huge data analytics and just really starting to run based on information and insight rather than anecdotes, if it turns out that your device is not proving to have a better outcome, and we know there are comorbidities, we know there are a lot of things that are outliers, but if it turns out that for the most part, in the mean, your device is not providing that outcome, then how do we partner with you differently clinically? And how do we share that information with you so that you can go back to your research and your development and perhaps work on what your device looks like? I think in the past, and I'm speaking for what I've seen over all these years, in supply chain, it was always that adversarial relationship, which we have decided is not positive moving forward.
No, I agree. I remember having a conversation with a physician, about his implant costs. And so I told him, if we can partner, we can work together, maybe you could look at this product versus another. And he looked me straight in the eye and he said, if I was replacing your knee, would you want me to work on something other than what I was trained on? I said, well, maybe I wouldn't. You know, he's coming from that perspective. So, you know, then it's the shift to, okay, well, if you want to use a Zimmer knee or, you know, whatever it might be, if you want to use this, then let's partner together to bring that price down. Because you're right. I mean, it's the relationship between the doctor and the manufacturer that we struggle with. And then there's been a lot of work in value analysis committees. We could spend a couple hours talking about that. But essentially getting the physicians, the nurses, the supply chain folks, all of us together and looking at how we're purchasing, what we're buying, how does it compare to other products, and getting buy-in from everybody versus having sourcing people looking for just the best price and bringing products in. I mean, that doesn't happen to any of us, right? And then we get complaints from nursing as to why you changed the product. So we're in the midst of that whole transition now to a value analysis program.
And I think to also sort of tackle your recommendation, which is really great, one of the things we've also done is, again, I'm really, my world is a little bit of a microcosm, it's supplier diversity, right? So one of the things we did when we decided that we really wanted to focus on total health and you know, the socioeconomic determinants, we actually created, every year we set goals and targets for supplier diversity in terms of staying members of the $1 billion roundtable. In past years, it's been only tier 1 spend. And that was sort of the goal. And in this past year, the goal that was approved by our CEO and chairman was tier 1 spend, tier 2 spend, and economic impact as part of the goal. So it was a 3-part goal. What that allows us to do then is to work with our prime suppliers to sort of say, we really need to understand your supply chain because, okay, maybe tier 1, but you really are gonna help us with the tier 2, right? So what suppliers are you looking at in your community? Not only, we're not just accepting your numbers. What are you reporting on in terms of numbers? We need your plan for how you're going to work with suppliers who may not be in the med-surg space, because there aren't a lot of diverse suppliers there that can service these big accounts, but what are you going to do specifically in your plan that becomes part of the contract for how you're gonna work with these 3 or 4 suppliers by name, targets that you feel comfortable delivering on to really develop, to also work with us to do development. So they sort of understand what our strategy is, the big primes. And then the third piece of that goal, the smaller piece, this year again was economic impact. We have our organization has a small percentage of the overall bonus compensation around economic impact. So when we talk to suppliers and we're getting ready to go to market and do an RFP for a big, you know, ginormous contract, we can sort of say, you know what, you're also, from a supplier diversity perspective, what small suppliers in the communities that you and we serve are you going to be working with? What is your specific plan over 5 years to help do, you know, capacity development? What are you going to do in terms of economic impact? So I think we're trying to really tackle it in a holistic way, because I think to your point, yeah, the big companies kind of know the Kaiser strategy, but we want to make sure you know it so that as you're looking at what your supply chain looks like, you recognize that we also expect you to support some up-and-coming suppliers as part of putting them in your supply chain so that they can grow and develop. So I think again, it's a new journey for us, but we're sort of looking at it, trying to really create a paradigm shift, because we know that we need to create that ecosystem. I mean, to your point and to your point, we can't do it alone. You know, health is not a Kaiser issue. It's a Toyota issue. It's a City of LA issue. It's a Goodwill issue. It's an issue that all of us need to be aware of and concerned about. So how do we collectively work to get that figured out?
So let me connect some dots for you, then we're gonna have some questions to you and get your thoughts. So what was just described here, I think any of you that work in supply chain is not unlike having secondary, tertiary requirements around quality or certain performance attributes or Lean Six Sigma programs or traceability of materials, right? You can think of almost any industry has some level of, hey, I'm going to work with my primary and then I want to see what they're doing with their secondary, et cetera, right? I think most of you have probably seen that to some degree. I can name lots of examples. The common theme here is people, right? our business is people. And so what we're saying is, what is our primary supplier? What are we doing with that primary supplier to help people? And what is the secondary doing to help people? And so my question to you is, does this strategy, or can this strategy apply to the corporate strategy of organizations who are in the business of cars, right, or food, right, where you're now saying, well, my focus is cars, and I want to have traceability of the metals that I'm using, of the bearings I'm using, and all that, all the way down to the primary, foundry, right? But oh, by the way, I'm also interested in the health of the people in that foundry. And why do I ask that? The one common theme all of us have is health affects all of us, right? Everybody likes to stay healthy. Everybody knows somebody, or hopefully doesn't know somebody, or hasn't been themselves in a hospital. But at some point in your life, you're going to have to deal with that part of our ecosystem. And healthcare costs in the United States are what percentage of the GDP? You guys can't answer. But anybody familiar with some of those numbers? They're in the news. That's how high they are. It's about 18%.
Yeah.
18% of the GDP in this country is spent on healthcare. I think it's the largest sector.
Well, it's largest of any country in the world.
And worse outcomes.
Average with worse outcomes, that's true. And average for OECD countries is about 12% or so. And for most low and middle income countries, it varies anywhere from 3 to 6%. But that's where you see also an opportunity. This is kind of not to derail you on a track, because if you're in the healthcare business or life sciences business, it's a huge opportunity, because almost China itself, if you do the statistics, next 10 years, it's $1 trillion healthcare opportunity. And so that's a whole different side.
Right. So you kind of understand why there's been a lot of effort on reducing those costs from the hospital perspective and supply chain, and how do we spend less, and how do we change the whole, the whole culture of doctors and healthcare, the hospitals and insurance companies and manufacturers, and how all of that works, because it is very different from other industries, right? Physicians can decide, and if one physician likes, this code and this scalpel, and they make a big enough deal about it, and they're a really good physician, well, guess what? The hospital will say, well, that physician is a big revenue generator for me, so I better get that more expensive gown for them, right? And then if you want to leverage that and say, well, we're spending $100 on this gown. A gown is just like what they wear when they're operating, right? They cover themselves, right? And we're spending $1 million on that gown for that physician. The balancing act that the care provider has to make is, well, if I don't do that, is that physician going to get upset with me and take their business to this other hospital, and I will lose $2 million in revenue? I'm just making a number. But those are the balancing acts that people in our industry have to make, right? And so now you see why it's important to also say, well, how do we just reduce demand, right? If we make people more healthy, well, guess what? Hopefully that physician that has that really expensive gown may not have as much work. Right? It doesn't make any sense, right? You say, well, why would you want to do that, right? You want to have more people coming. You want more sick people. But do we really? Do we want to have 25% GDP? So my question to you guys is, does it make sense to incorporate a strategy in other organizations to say, hey, how do we improve the health of our community?
There was a question there.
Good question there.
I had a question just kind of along the line about, from the consumer standpoint, being able to demand visibility into the product life cycle from their side, to say, being able to trace it back and be able to have some thoughts, some feedback on what products are actually going into.
Yeah, so we have one of the things that we're seeing a lot of, I don't know if it's this industry-wide, we call it consumerism.
Yes.
And you probably started to see there are a lot more apps and virtual connections with the care providers. There are various ways that you can interact with providers that you couldn't in the past. Secondly, newer generations are looking at service very differently from older generations. First of all, it's much more mobile, right? And it's much more, if you think of what we're able to do with Amazon, for example. When you go shopping, you can see the entire market for that one thing that you're trying to buy very quickly and kind of start comparing prices, right? And so people are starting to expect that from services and from other things. So we're starting to see a shift towards, hey, if I'm going to get that total knee replacement, I'd like to know what your price is.
Yes.
And your quality, your outcome.
Right.
And oh, by the way, you know, if I can choose from 5 different physicians or even 5 different hospital systems, I want to see all that. Wouldn't you like to see that?
Yes.
Yeah, wouldn't you? Right? So guess what? For us to, as that demand is growing, on our back end, we need to figure out how do we get all of that information consistently to you so that we're comparing apples to apples, because it's not as simple as what's your cost of goods and your labor costs. Yeah, I'm sorry, your material costs and your labor costs, and there's your total cost, right? And so we're spending a lot of time trying to figure that out so that we can come to that comparison, and then it makes the whole market much more transparent, more competitive, right? And so it drives some of the behaviors that you see in a lot of other industries already. And so there is a shift towards that we're already seeing, we're already living in. Answer your question.
You know, to add on to that, not only is this a shift for the providers, the healthcare providers, but what he's just described is a shift for our clinicians, our physicians. Being that transparent also reveals a number of things for that physician. When that patient, who we now call a patient consumer, because that's what they are, and they're doing a lot of research in advance, when that patient walks into your physician's practice and says, I'm armed with clinical evidence, not just cost, because you can't just approach it by cost. You have to approach it by clinical evidence. I have, if I'm going to have a total knee, and I know what the variability is between the 3 top manufacturers and all the commodity supplies, and I see a bottom line cost, just a bottom line cost of these 3, but there's no clinical variability between these 3, but you, Dr. A, have an allegiance, to his point earlier, to the vendor that trained you on how to insert that knee. So the physicians are not quite prepared to be challenged in that way. However, we are seeing an absolute trend where the patient is demanding that degree of information so that they're able to have those discussions in advance of getting the bill in the mail. And so we're preparing ourselves for that. However, I cannot say that all physicians are preparing themselves for that degree of change, because it challenges, in a sense, their authority and even their scientific understanding, because our physicians are scientists. So we are seeing that, and I'm fairly comfortable that everybody is seeing that here, and healthcare organizations such as ours. We've partnered with the Amazons of the world and the Microsofts of the world so that we can begin answering that demand. One of the sessions yesterday, I kind of wrote something down. I've spent so many years hearing about the future of healthcare, and I wrote, the future of healthcare is not the future is now. And so trying to shape an immediate response, good plans for demand, such as what you've just talked about, you have to do that now.
There's actually a great book describing that and kind of what the whole industry is going through. It's called The Patient Will See You Now.
Yeah.
If you're interested, it's chains all out.
I was curious, is there any low-hanging fruit right now? I mean, if you said that the U.S. is the most expensive system in the world and got not the best care out of compared to some other developed countries, is there one single driver of the high cost that is easily tackled right now, or is it a combination of the behaviours and the legal It's a large amount.
I think what, and maybe somebody else can better address this, but I think what I've read is just to your point, right? It's like, so when we go to a doctor, we tend to want, if it's you, I kind of don't want you to have all those tests that you're demanding because you have a headache, right? You just may need to take some Advil. But if it's me and I have a headache, I may want to have that gambit of tests. So part of what I understand is driving that cost is, you know, we are a country that we kind of, they have all the machines, they have all the tests. We have a headache, we believe we should get all of those tests, right?
Yes.
So that's one of the drivers of care. I think another driver of the high cost of healthcare is like Motz. In our organization, we went through this whole effort called supply chain transformation, maybe 2 or 3 years ago. And that was actually a massive change. I mean, when you talk about behavior on the clinician side, that was a change effort because Dr. Zhivago may want to only use a particular scalpel that may be a higher cost, but you have to really, in terms of supply chain transformation, you have to really do a whole change effort to get them to think differently and behave differently. And so a lot of it is the cost driven by, you know, physicians who like their brand of Band-Aid or scalpel and they're hoarding because, so there are lots of, I think there are lots of complex reasons why healthcare is more costly. And again, you know, not only is it more costly, but worse outcomes. And again, part of what we're recognizing is part of that worse outcome really is if you're looking at a certain population and you fix them, but they go back and 10 years down the road, all of those other behaviors that were never addressed reoccur, of course you're not going to have great healthcare outcomes because you didn't really address the fundamental cause. You address the clinical side, but all the smoking or the stress or just all of those other things were not really addressed in a way that is sustainable.
I don't think there is a silver bullet in trying to reduce the cost structure. In fact, we currently have a project that we are just undergoing, so I can talk to you maybe in a few months about what are some of the, looking at end-to-end, really, from manufacturer all the way up to the doorstep of the provider. You know, why is the cost so high? If you talk to the policy people, they will basically say there is not enough competition. That's why the costs are high. Now, there might be overall general competition, but healthcare sometimes often becomes very local. At a localized level, there may not be enough competition. Similarly, when you look at, say, life sciences, I want to separate out healthcare from life sciences because if you use the word healthcare, especially with MBA students, they think hospitals. And hospitals don't hire as many MBAs, so they have a recruiting mindset, so they're not interested. But if it's a life science companies, yes, I'm in, right? Because they hire a lot of MBAs. So if you look at life science companies again, when you say, how can there not be so much competition? Well, there are many life science companies, but competition again, if you based on therapeutic categories, there might be very limited competition. There's only one. I mean, take EpiPen, the whole thing that is blowing up in the press. You know, there is not much of a competition there. I mean, so I think there is a competition issue out there as well. It's well known that the payer situation in this country actually also, there's lack of visibility on the side of the consumer. Like, I don't see the bill. I mean, I don't only see the deductible part of the bill, but if you go to low middle income countries, you see it starkly. 80% of all healthcare spent in India is out of pocket. Then it becomes very stark. My mother just underwent 2 years ago heart valve surgery. And the way it was presented to me by the surgeon, basically, okay, here's the cost for the procedure, here is the cost for the valve, and here are 5 different valves I can put in there. Which one would you pick? And here is my recommendation for doing that. Medtronic is doing very interesting experimentation in India. They've actually done a pilot which is very successful for pacemakers. And what they're saying is typically all this service provision is bundled. So to pacemaker, you have to go to a hospital for somebody to put the pacemakers in you, right? The bill is typically bundled. And what they said is, why don't we unbundle this stuff? There is a product component, there's a service delivery component. The hospital will charge for the service delivery. And you know what? If automotives can have payment plans, we can have a payment plan on pacemakers. We can predict what your survival rate would be if the surgery is successful. And we will put you on a payment plan, so we reduce the cost structure. You pay a monthly bill for the pacemaker that is inside you. So you have to get very innovative in terms of how you think about this to reduce the cost structure And one is, to your point, right, I mean, work in the surrounding environment to reduce demand from the food deserts and all that stuff. Improve the economic well-being so that when there is need for health-seeking behavior, they have the affordability they have the economic well-being, strength to actually seek the healthcare behavior. And then you have to think about innovative ways to reduce your cost structure. So I mean, all of these things have to come together in trying to provide better health, and I believe that supply chain plays a very critical role in all of these aspects.
I'd like to, can I interject one thought about that too? I had an opportunity to work with the NHS for about a year, working with some of their trusts there. And one of the stark differences that I saw in reference to this whole cost issue, I found that they stuck fairly closely to protocols. And, you know, all of the same manufacturers, whether it was on the pharmaceutical side or the device manufacturer sides, they're all the same. They're not different from US to here. But one of the stark differences was that they found a way to reduce some of the variability. Unlike in the US, and I think we've all tried to communicate that a bit, there's such variability, so many options of our physicians, and while most hospitals set protocols and formularies, there's nothing to hold that physician accountable to standing to those protocols. And I'm going to give you a good example. One of the things that we know, and I think Kaiser has found this too, because I worked with Kaiser for a little while, we found that repeatedly physicians were ordering vitamin D test, repeatedly. There's no evidence that a vitamin D test has anything to do with a positive outcome for a patient. There's nothing. But the highest volume of tests were vitamin D requests. Now, if you take that out and you extrapolate that to the NHS, you didn't see that, because they realized that from a clinical standpoint, you didn't see any correlating positive outcomes as a result of high vitamin D deficiencies. So why do the test? But in the US, if you do a look at all the lab tests, you're going to see a lot of vitamin D requests.
And just to add, go ahead.
So just an observation, based on that comment about the cost, and actually I'd love to get your thoughts on it, is, a lot of my clients basically talk, in the life sciences industry, are talking about the regulatory impact also impacting the cost structure.
Sure.
So when you have regulations like conflict minerals, or you have unique device identification, from the FDA, you are obviously caught up in that also in terms of the fact that, if a stent maker, needs to provide that information to the FDA, that supply chain and that reverse supply chain has an allocated cost associated with what, you folks touch. So would love to get, some perspective
I
on
would
that.
not buy that argument when somebody has 36,000% gross margins to say that I can't track the conflict minerals and that's raising my cost structure. That's absolutely ridiculous. Because when companies in industries that have 20-30% gross margins are required to do this stuff and they're doing it, if medical device companies and pharma companies come and say, I can't do this stuff because that's raising my cost structure. If you look at supply chain, and I do this comparative, you can do, some of the supply chain faculty would say, a cash-to-cash cycle of life science companies. It is absolutely the worst.
Yeah.
Medical device industry and pharma industry have the worst cash-to-cash cycle because they are really running very inefficient supply chains in of themselves. And then come back and say, that's the reason I'm not able to, I just don't buy that. I'm sorry, I just cannot buy that.
What I would add to that, we're talking about variability, and you can see this in a lot of industries. If you're a sales rep, okay, I don't care what industry you pick, but it's rampant in healthcare, and you work in two hospitals that are part of the same organization, okay? Orange County and, I don't know where your other hospitals are, LA.
Yeah.
Okay, and I cover Southern Cal. I can go and have two separate conversations with two doctors on the golf course, cut two separate deals, get 20% margin here, 25% out of zero if you want, right? And guess what? I get more money, right? I'm the manufacturer, I make more money. Chances are those doctors don't know what they're paying in those two separate hospitals. They don't talk to each other. And I just made more money. And if you take it on the physician side or consumer side, if you don't have an integrated view or transparency that we talked about, as a consumer, right, I pay my deductible. I'll say, oh, it only cost me $10 to go see this physician. That's no big deal. But I don't see all the rest of the costs that then become part of my, my monthly premiums. And what does a physician do? Right? They're trying to increase revenue for the hospital, right? If it's a for-profit, let's say. Do they need those vitamin D tests? Really? Right? Or if you go in for one test and then you end up coming back 3 times for 3 other tests, how many times did they actually find it? Ever think about that? And I think that's part of what we're seeing in this, and it's if you read that book, you kind of see, this is from a physician's perspective, how our industry is changing because people are kind of tired of having 20% GDP going to healthcare. But I would say that's more of, what has happened over the last 100 years in this country, that, the structure has been a little different in others. And the small steps we're taking is really to change the culture so that the organizations and the individuals in those organizations start to look at things a little differently, because the competition you have in the automotive industry, in the food industry, the transparency does not exist in healthcare.
Since you're recommending a book, there's another book I would recommend. I can't remember the name right now. The last name of the author is Reed. He was a Financial Times correspondent. And what he did was he had a shoulder issue. And as a journalist, he then goes as a worldwide tour of different countries' health systems. So he gets diagnosed in US, he gets diagnosed in different countries in Europe, he goes to India, Japan, everybody, and using that lens, he describes the health systems of all of these countries. It's beautifully written. And then you get to understand really what's going on. And the only country to recommend surgery for him?
Was US.
Guess what?
US.
US. And where did he get the best health care? In an Ayurvedic hospital in India. Had nothing to do with your standard Western health system. But anyway, yeah.
One last question. I think we have 5 minutes to go here, so one more question.
So my question is somewhat on a different topic, perhaps might not be a bad idea, but we heard about Hanjin yesterday towards the end about how the entire supply chain can fall apart. And of course now in other industries, supply chains are so interconnected that when a single link between nodes and whatever falls apart, then everybody gets hurt. With regards to healthcare, particularly after several events in the past decade or so, we're seeing how preparation and resilience is particularly important, not necessarily within the hospital, but with upstream members of the supply chain. So the specific question is really how, let's say, Providence or Kaiser, how are you guys planning, or has the thought of going after or inclusion of your first-tier suppliers, probably not using the right terminology from the healthcare arena, but first-tier, second-tier suppliers, such that not only are they not causing severance into material movement, but that they can actually be able to ramp up, let's say if there's an earthquake here in Southern California or a big tsunami in Oregon or Washington.
Maybe I can give you guys an example, because we actually have lived this in the Ebola crisis of a year, 2 years ago now. And so there is collaboration with the upstream supply, but it is so bifurcated because again, we talked about variability. Just to give you a sense of variability, a typical hospital will have 6,000 to 8,000 med-surg supplies. That's not even including pharmaceuticals. 6,000 to 8,000. You go in there, you get a band, you say that's no big deal, but there's 6,000 to 8,000 different supplies across 3,000 to 4,000 suppliers. So So what we have done is collaborate with some of the key suppliers, but more importantly, because many of them don't have the capacity to ramp up like that, but I think the cool thing that we saw during the Ebola crisis was that we were partnering with other healthcare providers, right? Because we said, hey, there's very limited supply, there's an emergency, a national emergency, right? I don't know if I use the right term. What can we jointly do? Because you don't know where that Ebola patient is going to show up. And when they show up, you have to swarm with patient care, which means swarm with a lot of supplies, and we don't have enough for everyone. So we actually partnered with a number of different hospitals to basically share and communicate because the supply base is constrained. So that's one of the things that we do that. We work a little bit with the city of LA as well.
I was going to touch on that. That's what I'm from the emergency management department, and we're currently in the very beginning process, but trying to step in and talking to government, step in and assist that process and facilitate movement of cash flow.
To that point, I think the one that's most salient to me, is saline solution. You know, someone mentioned governmental regulations and the impact of some of our governmental issues really affecting us. We're moving into year number 3, I believe, and having difficulty still getting solutions. Well, the reality is why would that be so? Certainly, if you were to go outside this country, you can get saline solution. But we are in year number 3, and our Congress is still trying to figure out how to make that work, and that's a fact. It's in committee. One of the things that we will have to start looking at in terms of Providence St. Joe is how can we get to that source beyond the United States? We're stymied by regulation, import, export, the FDA, but it's the same saline solution, right? And even though we can partner for a short period of time, certainly it has now been 3 years. Anybody with good manufacturing practices should have been able to deal with that. But there's some underlying factor. And so I don't think we have an answer for it yet. We make do because we have great partnerships across the country, but we're all going after the same source, and after a while that doesn't work.
But that's another illustration of lack of sufficient competition in a commodity that you would think it's a commodity, right? Saline solution.
It is.
What's the big deal?
But fundamentally, you don't see the same type of supplier management in healthcare that you'd see in pretty much any other industry. Right? If you think of Toyota and what they've done in terms of managing upstream all the way to the raw supplies and holding suppliers accountable and getting the right level of execution and responsiveness, we don't have that in healthcare. That's part of what this whole transformation is about, is really to take best practices from other industries that have done this for decades and apply to an industry that, you know, had a free ride, you know, from a supply chain person's perspective. They've not known what it is to be held accountable to the level that other industries have been doing for years. And I think that is where we're going to start getting some leverage, you know, because if every hospital is saying we need more supply of saline, at some point those manufacturers are just going to have to invest in capacity. They can't just keep allocating because their patients' lives at risk, right?
Consolidation that's taking place will probably help with that.
Consolidation of supply base or
Hospital.
on the hospital side? It may. I mean, that is one of the impacts or the factors that limits our leverage, is that there are so many hospital systems, and even the largest hospital system in the country is not large enough to be, you know, like in aerospace, you have Boeing or Airbus. If they have a problem with aerospace parts, right, they get what they need, right? Because every company that supports them knows that if they don't please that company, and if they don't please Boeing or Airbus, they're going to lose their business. You're right. If Toyota needs something, they're going to get it, right? Because there are not that many manufacturers. But in healthcare, there are, what, 6,000 hospital companies in the U.S., something like that? So it's very difficult to leverage. We've formed partnerships to try and create that leverage, to try and create regulatory leverage to influence, you know, the UDI or, you know, barcoding standards. but it takes a long time. So it's just new to the industry.
Very quick follow-up perhaps. Does it have to do with the fact that, you know, when there's a newer part that comes off the assembly line and it doesn't have the horn, the blinker, right? That is clearly something that customers don't notice. Whereas us as human beings, you know, if I don't get a gallon of saline, there's such an indirect impact on the final outcome. I'm not saying it's not important,
You
but
could die. That's a direct impact.
you could, but it's not, it's a probability. It's not
Right.
an
Yeah.
absolute, whereas with a car, if the blinker's not there, it's an absolute that the car is, right? So is that what we're dealing with here? Is-
No.
Well, that's almost a quality question, and I would tell you that is an issue in our industry as well. I have seen, you know, this is our dirty little secret, but I've seen more recalls in healthcare than probably you've seen in a few years in the automotive. That makes all the headlines. You would not believe how many recalls there are in our industry. Now, these are recalls that are caught way before they ever touch you, which is great. But it's, you know, more than I've seen in food. You know, I've worked in food, I've worked in a number of industries. I've never seen you know, we get 2 to 3 recalls a week in healthcare. So that might give you some sense of, again, where the maturity of the supply base is relative to Toyota or other companies, right?
Well, if you're comparing apples to apples, Toyota and their suppliers also have returns. It happens all the time. Maybe some manufacturers who would have return components all the time as well, and that's what we're dealing with.
But the process is a lot tighter. I'm sorry?
That's a raw material level rather than the finished good.
Mhm.
Yeah, this is a finished good, and and you question, how is it that this was not caught at the manufacturer? Because many times they will let us, I mean, I'll give you a simple example, very tactical. I was in one of our hospitals, and the supply chain director there goes, and hey, look what I found. There's a little bag, sealed bag, for a sterile product that we use in the OR, operating room. We get millions of these things, right? And in that bag with the plastic gizmo, I don't remember what the actual part was a machine screw with some oil on it, sealed in the bag. So somewhere along the manufacturing line, some screw got loose, a little bit of machine oil, it got packaged with a product that ended up in the hospital. Now our folks catch that, but you kind of say, oh my God, can you imagine what would happen if you picked up a bag of food in a supermarket and you found a screw in it, right? How many times you hear it all over the news, right? We found somebody's fingernail in my tuna cake, or whatever, right?
That's
true.
happening
That's very true.
more and more.
What's that?
What you just
The
talked about.
fingernails?
Not the
I
nail,
better
but a hair or other things.
And you would think, oh, it's not a big deal, but it is a huge deal.
Yeah, we catch it.
And we catch it,
Yeah.
but it is huge. You say, oh my God, if there's a screw loose, what does that mean to that whole production line? And what does that tell me about that manufacturer? What else are they not checking? Right? This is stuff that is used on you. Not by choice, right? Some doctor's going to use it on you because you need it. So on that note,
I know, it's like they're all gonna go screaming.
No,
Screaming out of the
so
room.
that was just to give you some incentive of why total health is important.
Way to finish, Motz.
Right?
God,
All three of you are.
Wow.
The less
Scare 'em
chance
off,
you're gonna have
I'm
to
gonna
use
go with the
the,
Indian model, no surgery.
You're like, I'm so glad I'm an HR.
I know. I have my own problems.
All right.
All
I
right.
think we're way out of time, so I thank the panel. I appreciate you coming out.
Thank you.
Thank you.